Okay, so we are going to start with GI, interestingly. I think, again, as you very much start to get into not only our content in patho this semester, but also as you get farther into your clinicals throughout the semester, you're going to see a lot of overlap, and you're going to start to see a lot of practicality and a lot of usefulness and utility to what we're talking about in patho with what you're talking about and what you're seeing in the clinical setting. So let's start with GI. Structure and function of the digestive system. Again, just exact same as last semester. Here are your objectives. These should be your study guides for the exams. Okay, so the gastrointestinal tract, or as we would sometimes hear it more physiologically put, the alimentary canal, consists of obviously the following structures. I mean, I don't think I need to hash out and read this list of structures to you. But what I do want to talk to you about, and what I do want to spend a little time about on this morning is, okay, you know, I always like to put pictures, not only not just words. So here's your lovely picture of your GI tract. What I do want to spend some time about, actually let me go back to here, talking about a little bit this morning is some obvious functions, right? What's the importance of the function of the GI tract? So give me some things off the top of your head, obvious things that the GI tract is responsible for. Throw them out. Digestion, right. Absorption, because there is a difference, right? There's a difference between digestion and absorption. Good. What else? Excretion, good. Secretion, good. Is that what you said? Secretion? Yep. Yep. What else? Anything else? Metabolism, yes. There is some hormonal component of the GI system as well, and metabolism, good. Very good. Again, maybe not necessarily the most, first things that you think of, but that is excellent. Very true. You said digestion. I would also make sure that we sort of stipulate out both sort of the mechanical, sort of, the mastication and the churning, but also more of the chemical aspect of digestion. So that's good. Absorption and elimination or excretion. Very good. I mean, the obvious things. So, and here they are right here on the screen for you. Okay, so ingestion, propulsion of the food through the tract, secretion, both mechanical and chemical, digestion, absorption, which is probably one of the highest and I would say most important functions of the GI tract, and then obviously elimination of that waste. Very good. And as we talk about the GI tract and we talk about all those, structures on this list that I just gave here, you also have to consider that there are some accessory organs to the GI tract that are also very important and highly functional in this system. And that is obviously the liver, the pancreas, and the gallbladder. So those are certainly structures that we will certainly be discussing as we discuss the GI system as well. So just sort of keeping those in mind. So some of these functions may be very simple and very straightforward, and then others might be a little bit more complex, and there may be a little bit more complexities to the function of how these things work. And again, today we're going to be talking mostly about structure and function of the system, so that on Monday we can discuss what we start to see when there are some pathophysiological changes in our patients. So again, today will be more technical and more structural, and we'll be laying that good foundation and that good background for discussion of patients on Monday. Okay, so first, really quickly before we get into sort of the organs of the GI tract, let's talk a little bit about the tissue makeup first. So sort of the histology. So the GI tract consists of 4 layers. From the inside, the internal lumen working out, they're in this order. So mucosa, submucosa, muscularis, and serosa, or sometimes you hear it referred to as adventitia. These concentric layers, so if you take a cross-section of the GI tract, they're in concentric layers, vary in thickness. Each layer has sort of sublayers to them. And also very interestingly, between each one of these layers, there is a network of nerves that sort of run to and innervate each one of these layers of the GI tract. These networks of nerves are basically controlled by the autonomic nervous system. I mean, right, we know that the GI tract is sort of a, involuntary sort of organ. And it's these networks of nerves that control things like the mobility of chyme, so that, partially digested food is what we call chyme. So of chyme through the GI tract, of that secretion that we talked about, of sensation to the gut, of blood flow to the gut. And again, each one of these sort of networks of nerves lies sort of in between the layers of these tissues within the GI wall itself. And so you sort of see this picture here of each layer sort of broken apart and peeled apart, if you will, like an onion, right? So you see the 4 layers with their network of nerves in between those layers. And you sort of see each layer sort of pulled apart. Note that the serosa, the sort of most outer layer here, is continuous with a fold of tissue, of serous sort of membrane called the mesentery. And it's this mesentery, this tissue here that's sort of part of the serosa that actually attaches the GI system, attaches like the intestines to the abdominal wall. So this prevents, the colon or the small intestines from sort of flipping around and getting twisted inside the abdominal cavity. So again, the serosa has that mesentery layer that actually does anchor it to the inside of the abdominal wall. You also notice here that in the submucosal layers is where you'll actually find the digestive glands that empty into the lumen. So part of that secretion process that we talked about is where that sort of starts at that submucosal layer. All right. We're not going to spend a lot of time with the layers of the GI tract. I just need to mention that before we sort of move into the other organs. Any questions about this? All right, so now for the rest of the morning together, how we're going to sort of organize our time together is that we're going to look at each organ of the GI tract, or the alimentary canal, and we're going to sort of break each one of those organs down into 2 sort of categories. We're going to talk about the structure of that particular organ, and then we'll talk about the function of that particular organ. And again, I want this to sort of be clear to you. I want this to be, perhaps a little bit of a review, but I want to make sure that it's clear to you so that all of the things we talk about on Monday make that much more sense to you. Okay? So first things first, and we'll move through the GI system in the order in which the food contacts. Okay? So first, mouth and esophagus. Structure. I don't think I need to tell you much about the structure of the mouth, right? We know what it does. We know that it's that reservoir for chewing and mixing all of our food. What's interesting to me, though, is that as food particles become smaller because of sort of the chewing and the mastication process and moves around in the mouth and becomes into contact with our taste buds and olfactory nerves, all of those things are continuously stimulated and gives us that satisfaction of eating, right? So it's actually, the taste buds, or the papilla is the more scientific word for taste buds on our tongue, are actually chemoreceptors, right? So they're actually, chemically recepting the information that we've now put into our mouth, and it's the mixture of that with smell, with, the whole sort of bolus of food coming into contact with all of these things is what gives us that satisfaction of eating, which then makes us want to eat, right? That's kind of a basic evolutionary process of why we eat, because it's a positive, satisfying experience, right? And it all has to do with the fact that these taste buds are chemoreceptors. They're the ones that sort of note and sort of experience the salty, the sour, the bitter, the sweet, whatever it is that we may be eating. So it's kind of an interesting sort of scientific look at, why we eat and why we want to eat. Also, interestingly, when you're looking at sort of the way that the taste buds work with the olfactory nerves that innervate our mouth and et cetera, it's the taste and the food odor that actually helps to initiate the digestive process. Why is that? I'm sure you know this. This is review. But how is it that the odor of food and the taste of food actually starts to initiate digestion and breakdown of the food? How does that happen? Yes, it stimulates saliva secretion. And there is specifically an enzyme in our saliva called amylase. I'm sure this is a little bit of a review, that starts to break down one particular type of some of the nutrients that we take in. And what is that? Anyone know or remember? Carbohydrates. Very good. Very good. So it's the taste and the food odors that actually help to initiate salivation and, interestingly, secretion of gastric juices. So not only does it increase our actual salivation, but it actually increases the secretion of the juices in our stomach as well. So very interestingly, I think it's kind of fascinating how it actually starts the digestion process before you've even completely swallowed the food, right? We're already starting to digest. So that's the structure there for you. And then obviously the function of the mouth and the esophagus have to do with two things, either the salivation process, which we've just started talking about, or the actual swallowing. So let's talk a little bit about those functions as well. So first, salivation. We know that this happens with our pairs of salivary glands. So you have, and I'll go to the next slide here so you can actually visualize. So you have your submandibular gland, which is right under the mandible, obviously, thus the name. You have your parotid gland, which is your big parotid gland that's sort of, the biggest of the salivary glands, which is located right here. And then you have sublingual glands that are actually underneath your tongue. So sublingual, underneath your tongue. And interestingly, together, in a 24-hour period, these glands secrete greater than or approximately around a liter of saliva a day. Ugh. It kind of makes me queasy just thinking about that. But really, if you think about how many times we clear our throat, how many times we clear our mouth, how many times we swallow throughout the day, it's probably not that hard to believe, but it's just crazy to think about that these little salivary glands pour out that much saliva to fill up like a liter IV bag in a 24-hour period. Kind of crazy. But again, important because of the way that it actually starts the digestion process. Okay. Saliva is water, also mixed with mucus and mixed with some other things like sodium, bicarb, chloride, potassium, and that very important enzyme amylase, which we've already discussed. It is controlled by sympathetic and parasympathetic fibers. Specifically, the cholinergic parasympathetic fibers are the ones that stimulate the salivary glands. So if cholinergic stimulation increases the production of salivary glands, is anyone familiar with the form or the class of medications anticholinergics? Have you guys talked about that in pharmacology? Okay, so if cholinergic stimulation stimulates salivary glands to produce saliva, what would anticholinergics do? Dry you out, right? Dry out the salivary glands, dry out the mouth, dry out the mucous membranes. And why, clinically speaking, might that be important? Why would we want to, give someone an anticholinergic? Anyone know of any clinical situations or clinical reasons why an anticholinergic might be warranted for a patient? Yeah.
Like somebody who has either airway clearance problems or trach where they need to make sure there's no extra phlegm or extra.
Great. Yeah, very good, very good. Anyone who's got sort of airway clearance problems or difficulty swallowing or things like that. When I worked in the Department of Neurology at Penn, and I worked with ALS patients, they have a lot of weakness in their sort of mouth and their throat area, so they're not able to swallow and clear that liter of saliva a day, so they drool. They have really bad drooling problem, oftentimes because they can't clear that, and we would oftentimes put them on an anticholinergic. What's a big anticholinergic drug that's used quite commonly in some form or another? Atropine. Good, good. And I saw another hand. Was there another suggestion? Yeah. Not necessarily, because honestly, the issue with cystic fibrosis patients is that they have too much of their secretions, but the secretions are too thick, and an anticholinergic may actually even thicken that up and dry it out even more. Yeah. The other situation I was going to give, and this kind of goes with Megan's line of work, is preoperative. Oftentimes they give anticholinergics because to decrease the secretions during an operative procedure, either because of needing to intubate or also because of risks of aspiration and things like that. So oftentimes you'll see some type of anticholinergic given as sort of a preoperative medication before someone going under anesthesia or being intubated because of to basically decrease their secretions. So that's another good sort of clinical way that we sort of care about cholinergic or anticholinergic stimulation. Good, very good. Okay. Okay, the next function, swallowing. Interestingly, the esophagus is part of the swallowing mechanism, so to speak, because the upper 1/3 of the esophagus contains striated muscle, which we know striated muscle is voluntary muscle, right? So the upper part of the esophagus actually assists and helps in the actual swallowing of that food. Now, we know that obviously the lower portions, lower 2/3 of the esophagus contains more involuntary smooth muscle, because that's the muscle that sort of is controlled, that controls peristalsis to sort of move that food down from the esophagus into the stomach. But interestingly, that the top part actually is voluntary. It does actually contract and assist with your actual voluntary swallow. So the top part there, that top 1/3, is actually innervated by motor neurons. And then that lower 2/3 is innervated more by cholinergic fibers, stimulated by the vagus nerve. Just kind of interesting little information for you. It's controlled by the vagus nerve and cholinergic fibers. Okay. Then we also know that at each end of the esophagus, at the top of the esophagus and at the bottom, the esophagus gets closed by some sphincters, right? At the upper part of the esophageal sphincter, it keeps air from entering the esophagus during respiration. So it closes during respiration so that there's not a lot of air filling up our GI system. The lower esophageal sphincter, so the one right before you enter into the stomach, obviously prevents regurgitation from the stomach back up into the esophagus. Why do we care about that? Why is there such a why do we care about regurg from stomach back up into the esophagus? The acid is very corrosive and can be very inflammatory and break down the tissue of the esophagus. Very good. Very good. So again, you have two different reasons for those two upper and lower esophageal sphincters. Good. All right. Then, when you're discussing that movement of food from the esophagus down into the stomach, you also have to discuss peristalsis. And again, you're familiar with peristalsis. But I think what's interesting is that peristalsis, the nerves sense the changes in the esophagus with tension on the wall. So as you move food down the esophagus, the nerves sense that tension, that fullness, so to speak, of the esophagus, and it actually causes peristalsis to increase. So the way I kind of think about it is, last semester when we talked about the Frank Starling law of the heart, and the harder the pull or the stretch, the harder it snaps back, right, when we're talking about ventricles. It's kind of the same thing with the esophagus and peristalsis. The bigger bolus of food that you put in the esophagus, the harder that peristalsis squeezes and pushes, right? The more tension it feels, the harder it pushes, the harder it contracts. And that's kind of the way that peristalsis plays that part in swallowing, and also is innervated to be able to get that food down from the esophagus down into the stomach. And technically speaking, swallowing does actually have two phases to it as well. You have the oral pharyngeal phase, which is that voluntary phase of us chewing and swallowing. We know that basically consists of the food then moving back to the back of the mouth. And what also happens at that time is obviously that respirations are inhibited, and the epiglottis covers the larynx so that we don't have, covers the larynx so that you don't have food then moving into the respiratory tract. And this is a very short phase. The oral pharyngeal phase is literally like less than a second. Think how quickly you can swallow, right? That's the oral pharyngeal phase. The esophageal phase is the more involuntary phase of swallowing, and that is obviously longer. This is those wave-like peristaltic contractions that move food down to the stomach. And oftentimes it doesn't take very long either, but it's obviously longer than swallowing. It's like 5 to 6 seconds is usually what the esophageal phase is. But again, an involuntary part of the phase. Okay. Any questions about the esophagus before we move on into stomach? Good? Okay. Okay, again, not going to spend a lot of time talking to you about what the stomach is. I think you're pretty familiar with that. Again, we know that it secretes digestive juices. It mixes the food with those digestive liquids. It propels that partially digested food, again, we call that chyme, into the duodenum. And again, the duodenum is that first part of the small intestine. Functionally, you've got different areas of the stomach. So you've got the fundus, which is the upper portion. You've got the body, which is sort of the middle portion. And then the antrum is the lower part of the stomach. Interestingly, as you move down the stomach, those muscle layers become progressively thicker. Especially like in the body and the antrum, the muscle in the stomach there is much bigger and sort of more muscular, so to speak, than in the fundus. Physiologically speaking, why may that be? Why would you find that change in the muscle of the organ? Right, because now as it moves down into the stomach, you're really talking about it needs to be able to functionally push that chyme and with, without any sort of backflow or without any sort of residual of getting that chyme from the stomach down into the duodenum, down into the small intestines. Very good. Very good. It's also there in those lower parts of the stomach, the body, and the antrum, where food really does need to be mixed well and pushed well and, sort of get more blended with those digestive juices that are part of, the liquids in the stomach. So that needs to get mixed really well. So it just needs to be more muscular. It needs to be able to squeeze and do that. Also, just really quickly here, blood supply from the stomach is huge. Really a lot of cardiac output, a lot of blood flow goes to the stomach during digestion of chyme. In fact, blood supply is so abundant to the actual stomach that nearly almost every single artery that goes to the stomach would need to be completely occluded before you even start to see like ischemic changes occurring to the stomach. Because there's just so many different ways and so many collateral sort of blood flow to the stomach that really you never really see ischemic changes going on to the stomach, because if something's blocked, there's so much other blood flow getting to the stomach. So you really don't see ischemic changes unless things are pretty well shut off to the stomach, and obviously that person would be pretty sick. So blood supply comes from the branch of the celiac artery, which branches right off from the aorta. So a lot of blood flow and blood supply to the stomach. Yeah. Both. Yeah, good question. He said, is that for nutrition or to power the muscle? And it's honestly for both. Both functions are highly important, and therefore takes a lot of that blood, a lot of that cardiac output. Okay, and then function of the stomach. So gastric motility and gastric secretion are the two big functions of the stomach. So we'll talk about that in just a second here. So let's flip through here. Here's the picture for you, seeing all of those layers. Just like to give you some visualization of those muscle layers getting thicker as you move down. Okay, so now let's talk a little bit about gastric motility. So gastric motility sort of starts with that mechanical action of swallowing, right? It causes, when you swallow, again, interestingly, even though you feel like all the swallowing activity is going on here, when you swallow, it actually causes the fundus of the stomach to relax and to receive the bolus of that chyme, of that food from the esophagus down into the stomach. There's a lot of different enzymes and hormones that get sort of released and need to be part of that process. Gastrin, motilin, and the vagus nerve actually increase contraction of peristalsis. And interestingly, secretin, cholecystokinin, and a sympathetic nervous system actually decreases contraction of peristalsis. So depending on what the body needs, depending on what's going on, you either have things that are increasing contraction of peristalsis, or you have things that are decreasing contraction of peristalsis. So look at this. Really interesting, right? When we talked a lot last semester about how the sympathetic nervous system often is the nervous system that sort of revs up the body, right? Increases heart rate, increases blood pressure, increases awareness and acuity and things like that. Why would the sympathetic nervous system actually decrease activity in the GI system? It's like the opposite of every other sort of, impact that it has on every other system in the body. Why is that? Yeah. Right, exactly, perfect. You do not need the energy, the blood flow, the ATP, whatever you would honestly be sending to the stomach. That's not a high priority in a fight or flight sort of situation. Well said, perfectly said. So yes, so sympathetic nervous system actually decreases contraction of peristalsis. So oftentimes this is why, like, if you're really exerting a lot of energy, you're going out for a run or you're picking up a game of basketball or whatever, and you actually kind of feel like, oh my God, I'm going to throw up when you're like really exerting yourself. I don't know if any of you have done that. I definitely have, especially when I'm out of shape and I'm out trying to run 5 miles as if I can do this. And you're like, oh my God, I'm going to throw up. I honestly think that has to do with the decrease in the motility going on in your GI system, because your sympathetic nervous system is shunting blood away from your GI system. It's decreasing the contraction of peristalsis and moving it to other places that are more important. So that's oftentimes why you feel that feeling with heavy exertion, because the GI system is just not important during more sympathetic sort of fight or flight kind of situations. Okay, and then the other sort of aspect of gastric motility is gastric emptying. So swallowing kind of fills it up, right? But then we have to be able to get that chyme and that bolus of food then out of the stomach as well. So gastric emptying is the mixing and the emptying of the chyme from the stomach into the duodenum, which can take several hours. And obviously the rate of how fast it does occur depends on how much you ate, so the volume, the osmotic pressure, the chemical composition of the gastric contents, etc. So it really can, depend on what you ate and sort of the other sort of components about how long this gastric emptying occurs. But it's certainly part of that gastric motility function of the stomach. In the resting state, interestingly, the stomach is really small. It really only contains about 50 mils of fluid in a resting state when you haven't had a meal, it's been several hours since a meal kind of thing. And then, as you start to, eat and you start to move that chyme down into the esophagus, into the stomach, with each peristaltic wave, a small portion of the chyme passes through that pylorus into the duodenum. So that's to say that as you eat more, as you're eating a new meal, whatever was sort of in the stomach actually gets pushed and sort of propelled out of the stomach into the duodenum, essentially to make more room for the new food that's coming in, right? And so that's kind of part of this sort of gastric emptying, is that there's sort of a reflex. As more comes in, you try to empty out what's currently there, or what's residually there. Normally, there really shouldn't be any regurgitation from the duodenum back up into the stomach. And, as I mentioned, larger volumes of food increase gastric pressure, they increase peristalsis, and they would then obviously increase the rate of emptying, increase the rate of passing that food from the stomach into the duodenum. Okay. So the next sort of function is gastric secretion. So the stomach secretes a lot of gastric juices. Two of the main important ones obviously would be acids, right? The gastric acid that our stomach produces to be able to dissolve those food fibers. And also it's such an acidic environment that it actually acts as a bactericide as well. We know that, there's nothing sterile about the stuff we put in our mouth, right? So to decrease that risk of infection of, that basically open access of our stomach to the outside world, oftentimes that a very acidic, low pH environment acts as a bactericide as well. Also very important are enzymes like pepsin. They break down protein. They form polypeptides in our stomach. There's also other things like hormones, intrinsic factors, etc., that are also present in our stomach. The problem is, though, is that both enzymes and acid can be because it's a high pH, or not high pH, a high acidic, low pH environment, it can be very, very harsh to the inner sort of layer of the stomach. And that's what makes the mucus layer, that mucosal layer of the gastric organ, so important, because it actually protects the mucosa of the stomach from its own juices, right? So from the acid and from the pepsin. So it's very important that you have a good, healthy mucus layer there in the stomach. There are things like ischemia to the stomach, like certain bacteria like H. pylori, aspirin, that actually can break down that mucus layer, that mucus sort of protective covering in the stomach. When that occurs, what do you see? What do you start to see when you actually have breakdown of that mucosal layer in the stomach from any of these factors that we've talked about? Yeah. Ulcerations, very good. So you can see, originally you start to see sort of inflammation, and then that inflammation can get so bad that it actually causes an ulceration. Very good. And that's when you start to see ulcers in the, gastric ulcers. Very good. So again, very important that you have a good sort of balance and a good combination of the mucus with the acid, with the enzymes, and the other factors there in the stomach. Most of the gastric glands are located in the fundus in the body of the stomach. Rate of secretion certainly does vary with these juices, does vary depending on what time of day you're talking about. When do you think our gastric juices are the highest? Anybody have a guess? That's a good guess. Most people say morning, but it's actually at night. It's actually higher in the PM. Honestly, probably just because as you eat more throughout the day, your body needs more, right? It needs more to be able to sort of digest and create, do all of that sort of important gastric secretion function. So it's actually higher in the afternoon or evening. And then obviously, because there's such important sort of pH aspect to a lot of the gastric secretions found in the stomach, loss of gastric juices can cause major fluid and electrolyte imbalances. Anyone know what I'm talking? Like, what kind of things could you lose gastric juices with? Yeah, nausea, vomiting, and then obviously diarrhea as well. So good. Good, very good. That's important because it can actually really change the pH of someone's system. When all that fluid and electrolyte balance that we talked about last semester comes right back into this discussion as well. Good. Very good. All right. Any questions about that? So obviously a lot of these things like the enzymes and the acids and the mucus are secreted right into the stomach. But obviously more of the hormonal impact of gastric secretion. Hormones obviously are secreted into the blood from endocrine organs, and then they travel to the target tissue, so they would travel to the stomach. So most of these things are secreted right into the stomach, except for the hormones. The blood carries that to the stomach. Okay. And then the last little content here about gastric secretion is phases of this gastric secretion. We won't spend a lot of time on this, but there are 3 phases. So the first one is more of that cephalic phase we talked about at the beginning, just stimulated by thinking about food, smelling food, tasting food, right? It actually does increase the secretion of gastric juices just by thinking, smelling, or smelling it. Tasting it. Gastric phase is then obviously stimulated by the distension of the stomach. So again, as you put that bolus of food into the stomach and it does stretch and feel that distension, it's going to increase now more of those secretions of those important liquids. And then the intestinal phase is actually stimulated by histamine and digested proteins. So there is a little bit more of the gastric secretion and digestion that occurs even once you get out of the stomach and more into that small intestinal sort of duodenal part of the movement of the chyme through the GI tract. So just kind of an interesting there. Influenced by numerous stimuli that together sort of facilitate digestion. So all 3 of these things have to occur for proper digestion to happen. All of these phases, though, promote secretion of acid by the stomach. So very interesting. All right. So in discussion of the small intestines, we'll now leave the stomach and talk a little bit about the small intestine. So structure you see there, we know that functionally it's divided into 3 segments, the duodenum being the first, that receives the food from the stomach, jejunum, and the ileum. The ileum is then what dumps right from the small intestine into the large intestine, so into the colon, through this valve called the ileocecal valve. And we'll talk more about that later as we talk about the colon and then as we talk about more alterations in GI function next week. And then the other part of the thing that you have to think about when you're thinking about structure of the small intestines is the peritoneum. So the peritoneum is that serous membrane that sort of surrounds all of the organs in the abdominal cavity and in the pelvic cavity. In my mind, it's very analogous to some of the other sort of pleural membranes that we've talked about already. So like the pericardium that we talked about, the pleura that lines the stomach, the lungs. It's very similar to that type of sort of, pleural layer. It contains just enough fluid to lubricate and prevent friction of organs in that abdominal cavity. So again, it's very similar to those other pleural membranes that we've talked about already in this course. And there is that cavity, the space between those 2 layers, that's filled with a little bit of fluid to lubricate and prevent friction. So again, you'll find that sort of covering and surrounding basically all of the organs and the abdominal cavity itself. All right. So, let's see, we talked about the ileocecal valve controlling the flow of digested material from the ileum to the large intestines. I just wanted to make sure that's clear because we're going to really focus on some alterations with that coming up. Okay, good. All right, so now, to be honest with you, now as we move into the small intestine, the structure of the small intestine is a little bit more complicated. It has a little bit more nuances to it than the stomach or the esophagus. And that if the structure is more complex, it should only make sense to you then that the functions of the small intestines are more complex than the stomach and the esophagus. So let's talk a little bit about both of those. So structurally, if you would do, again, a cross-section of the small intestines, again, doesn't matter which section, first, middle, or last, of the small intestines. If you would do a cross-section of the small intestines, you would see these mucosal folds, or what they call plica. So if this is the big sort of internal cross-section of the lumen of the small intestines, you would see this. Within the entire lumen of the small intestines, there's these membranes that are basically just folded on top of each other, right? Called plica. Now, the purpose of this plica, the purpose of the internal membrane of the small intestines being sort of structured like this is twofold, really. It slows down the passage of food, and it also provides increased surface area for absorption. Right? So it slows down the passage of food, which provides more time for digestion and for absorption to occur. And it also provides more surface area for those things to occur. Right? So that's kind of structurally the purpose of these mucosal folds. Then, lining on the outside of each one of these mucosal folds are the villi. Okay? And again, this may be a review for you, but I just want to make sure we're all on the same page. So again, through the entire cross-section here, of these mucosal folds, you would see these villi. Okay? Little hair-like projections that come right off of those mucosal folds. Villi are the functional unit of the intestine. And what I mean by that is they are basically the big sort of responsible unit for absorption occurring in the small intestines. Okay? And they also secrete enzymes necessary for more digestion and absorption processes to occur. But they are the big absorptive property, so to speak, of the small intestine. So they are the structural, functional unit of the intestine. They are basically what make the intestine work. Okay? So absorption occurs through the villi. They're composed of columnar epithelial cells, and within the villi, there are microvilli. So I'm not going to do this on the entire thing, but within each villi, there's also more hair-like projections off of each one of those, right? And again, that just increases the surface area, increases the absorption and digestive surface area, and creates basically what we call the brush border of the inside of the small intestine. Okay. Again, what I really want you to understand about this is that it increases surface area for absorption and slows down the passage of food to give it more time to be absorbed. There are also a couple other structures in the small intestine that I want you to be familiar with. First thing is the lamina propria. This lies kind of underneath, sort of beneath these epithelial cells, and there's a picture on the next slide. But it lies sort of beneath the epithelial cells, and they're responsible for producing immunoglobulins. Again, why is that important? Why are we so concerned with the immunity of the bowel, of the GI system? Why is there a whole structure devoted to it in the small intestine? What do you think? Because we eat bad stuff, right? It has to do with the immunity of the bowel, in that, like I said, there's not necessarily sterile things that come into our GI system, right? Not only can, just fruits and vegetables have bacteria on them, obviously eating raw or partly raw food or sushi or beef or whatever it may be, there's a lot of things that our GI system comes into contact to that may not necessarily be completely healthy for the GI system. And so there is a big sort of interplay between the immune system and the GI system through this layer, through this lamina propria, to protect ourselves and to protect immunity of the bowel and keep the bad stuff out of the GI tract or from being absorbed out of the GI tract into our bloodstream, etc. Okay, and then the other structure really quickly is the lacteals. This is more of a lymphatic channel that sort of runs in and through all of these sort of mucosal folds that's responsible for absorption and transport of fat molecules. So I don't know if you've ever heard, but it's sort of a known fact that after a pretty big fatty meal, so a big old juicy steak or a big whopping cheeseburger or something, that if you would actually take a blood sample and look at the sort of fat content of the blood, it actually is fattier, right? It actually is has more lipid content in the blood after a big fatty meal. And that is because absorption and transportation of fat molecules actually gets absorbed out of the GI tract into the bloodstream from lacteals. So if you've ever wondered, like, okay, how does someone with like clogged coronary arteries get that? Like, where does that lipid stuff come from? Why does their diet directly impact the amount of lipids in their blood? It's because of the absorption of those lipids in their small intestines through these lacteals. I think I remember someone telling me in nursing school one time, one of our teachers when we were talking about this, that if you would literally look at like a vial of blood after a really big fatty meal, that you can actually, like, I don't know, under the microscope or in the lab or something, like it actually looks lighter. It looks pinker instead of red because of the lipid content in that blood. And that's because of the absorption through the lacteals. And here's a great picture here for you. So as a cross-section of each one of these sort of mucosal folds, you see this lacteal running right up into the middle of each one of these folds, right? So it's absorbing all of that as it moves through and passes through those mucosal folds. Yeah?
Like when they're taking your blood for life insurance, and they're testing your cholesterol, if you just don't eat anything fatty.
Have a kale salad before you show up. Probably not, because it's more of a cumulative effect. That one healthy lunch probably isn't going to impact your total cholesterol. Yeah, but why not? But why not try, right? Good. All right. So now we're going to finally get to the function of the small intestines. We kind of already talked about the function because you kind of have to talk about the function when you're talking about the structure. But now let's talk more specifically about some of the functions of the small intestine. So we talked about immunity, right? We've already said that. We've talked about intestinal digestion and absorption. And we've talked a little bit about intestinal motility as well already. But let's talk a little bit more sort of specifically about each one of these as we move forward. Again, since the structure is more complicated of the small intestines, therefore, obviously, the function is going to be more complicated as well. Okay, so unfortunately, this slide is pretty technical. And what I want you to just basically get away from this slide is that there is that major role in immune defenses in our GI system by killing a lot of the different microorganisms that get into our GI system. So this is through secretion of antibodies, like we've talked about already. There are specific cells in the GI system called Paneth cells that produce compounds called defensins and other sort of antibiotic peptides that, again, help with that mucosal immunity. And then there are Peyer's patches. These are collections of lymphocytes, plasma cells, macrophages, all those good cellular immunity words we talked about last semester, that produce immune globulins as a component of that gut-associated lymph tissue in the small intestine. So some of those lacteals and the other layers actually kind of help with that protecting of the gut and protecting of the small intestines. Very important for antigen processing and immune defenses. And that's really just what I want you to sort of get away from this slide, is that importance of the fact that our GI system has to be covered very, very well by the immune system because of what kind of, like you said, nasty stuff that we bombard our GI system with every day, right? And that's what I basically just want you to understand about that function. Nothing sterile about what we eat. All right. And then how about intestinal digestion and absorption, one of the other big functions of the intestinal tract. The process of digestion is initiated in the stomach by the actions of some of those things we talked about already, so the hydrochloric acid and the pepsin. Digestion continues in the small intestines by actions of other things, so pancreatic enzymes, intestinal enzymes, and bile salts. So what I want you to understand about this slide is that the process of digestion in the small intestine can actually be started by just even sensing that there's some digestion going on in the stomach, right? Hydrochloric acid and pepsin. But I think what's not so intuitive is that digestion is not complete. And what I mean by digestion is not absorption, but digestion is not complete. The breakdown, of the food is not complete by the time the food leaves the stomach. There actually is a little bit more of the actual mechanical, chemical breakdown of food, even when it gets into the small intestine. So it's not completely digested by the time it gets to the small intestines. So it's with the help of a lot of those accessory organs, like the pancreas, like the liver, like the gallbladder, that continued digestion occurs in the small intestine. So it needs more help from the pancreas secreting pancreatic enzymes, and the pancreas secretes it right into the small intestine. Same thing with the bile salts from the liver. The gallbladder collects them from the liver and then dumps them right into the small intestines. So there is continued digestion with the help of those accessory muscles in the small intestine still. So I just want to make sure that's clear to you. Chyme does pass into the duodenum. It's in a very liquid form, but there are still some small undigested particles of food in that needs to continue to digest once it reaches the duodenum. So, with the help of those accessory organs. Okay? And it's here that the major nutrients in the food that we eat are broken down into their smaller constituents. So basically everything until you get to the small intestines is all mechanical. It's just digestion and breaking down. There's no absorption, there is no goodies, no nutrients, nothing that gets basically into our bloodstream or into our system from the stomach. All of this now starts to happen in the small intestines. So carbohydrates, proteins, fats, water, electrolytes, all of these things now start to get absorbed through the small intestines. Absorbed across that intestinal mucosa by active transport and diffusion and all those good things that we talked about last semester. None of this happens until the chyme gets to the small intestines. So that's why it's so important, right? That's why the small intestine is so important and the health of the small intestine is so important. That we really do start to now absorb the nutritional content of whatever we've eaten in the small intestine. And this is a really good picture for you, I think, that shows you kind of what is absorbed where in the small intestines. And look at the stomach. Water and alcohol get absorbed in the stomach. None of the good sort of nutritional content of the food that we eat even starts to get absorbed until you get into the duodenum. Okay? And then you see what's in the jejunum and what's in the ileum, right? And really, that's where all the nutrition comes from, is from the small intestine, because look, once you get into the colon, we're just talking about basically water and electrolytes. So all of the nutritional content that we eat gets absorbed in the small intestines. So now, wink, wink, if you're thinking about what we talk about next week, if we've got some type of alteration in health of the small intestines, we understand the sort of impact of that, right? Nutritionally, the impact of some sort of alteration in the small intestine. Hope that makes sense to you. Okay, good. Yeah.
During the cancer unit, when we talked about how bad it is to keep your stomach longer,
Yes.
did it sit where it's fast absorbed or kind of sludge through the entire system?
In that case, we're talking more usually about the large intestine. Yeah. Usually there's a higher link of the way the food sort of sits in the colon. And so that we're talking more about the large intestine than the small intestine in that respect. Does that answer your question? Yeah. And it does just sit, yeah, in the colon. Yeah. You're like, yummy. Okay. Intestinal motility, the last function. So the movement of the small intestine facilitates both digestion and absorption. We said that already. And the actual motility is affected by two movements. So you've got the peristalsis. So peristalsis occurs in the esophagus and the stomach, and it also does occur in the small intestine. And it's those waves of contraction that sort of push the chyme through. More of like an up and down longitudinal kind of wave of contraction. The one type of motility or one type of movement that you may not be as familiar with is haustral segmentation. This is the type of contraction that occurs in the small intestine that's not longitudinal. It's like back and forth, like this. So it's localized rhythmic contraction of the circular muscle sort of rings that divide and sort of mix the chyme. So it actually is more of like a washing machine kind of effect, like the back and forth kind of, where the peristalsis actually pushes it through. So it's this combination of the back and forth sort of contraction and the longitudinal contraction that actually propels that chyme through the small intestine and gets it to the colon. This haustral segmentation is very helpful, in sort of this back and forth sort of wash machine kind of thing that's helpful in blending the secretions of those accessory organs with the chyme. So that's what really mixes and churns the pancreatic enzymes, the bile salts, etc., with those, with the chyme in the small intestines, as opposed to the peristalsis pushing it through. Hope that makes sense. Okay, large intestine. It's long, 1.5 meters. And we know that the first sort of part of the large intestine is the cecum. That's why that ileocecal valve is named what it is, because it connects the ileum to the cecum. So ileocecal valve, connecting the small to the large intestine. We know that the appendix is sort of there and doesn't really do much. And then we know, right, with the colon that we've got a kind of 4 different sections, right? So if you're looking at this, so you're looking at the colon. Here's our small intestines, right? Okay, empties into the ileocecal valve here in the cecum. The colon has an ascending, transverse or transcending, descending part, and then sort of the sigmoid colon is right before you empty into the rectum, right? So ascending, transverse, descending, and sigmoid. Now, as chyme moves through the colon, we've already said that most of the water gets absorbed, water and electrolytes get absorbed in the colon. What would you expect to see as the actual content of the stool as you move through the colon? So here versus here. What would the stool look like here as opposed to here in terms of its liquid content? It's going to be more liquidy here in the cecal, the cecum, as opposed to here right before you get to the sigmoid or the rectum or the anus. Very good. Because that is where basically most of the water is absorbed, is in the colon, right? So that's very important to sort of understand. So the ileocecal valve admits the chyme from the ileum to the cecum. There is another sphincter at the end of the colon called the old Byrne sphincter, which controls the movement of waste from the sigmoid colon down into the rectum to be expelled, obviously. And there's an internal and an external anal sphincter that sort of controls that muscle here at the end. But what I really want you to focus on is the movement of and what you would expect of the kind of volume or the mass through that colon. And we're going to talk about that more specifically in just a second. Okay, so here's a good picture for you. Here's that ileocecal valve. Okay. Okay, so we need to talk now about the function of the large intestine. And again, I want to spend some time on this because I want you to truly understand, sort of what you're seeing in your patients at the bedside. And if you understand what's happening in the colon and what should be happening in the colon, you can start to understand some of the alterations that you may see. Okay? So first things first, we're going to get a little technical and then I'm going to kind of make it more sort of applicable to you. So one of the big functions obviously of the large intestine is motility, right? So colonic movement is segmental, so it's that haustral segmentation again, that wash machine back and forth. And interestingly, also, motility is very much affected by the gastrocolic reflex. And what that is that the gastrocolic reflex initiates propulsion in the entire colon, usually during or immediately after eating, when chyme enters from the ileum, right? So it's no surprise, right? Especially if we're talking to patients that are having some GI issues or that they are having some issues with constipation or bowel training or whatever it may be, that they will tell you that after they eat their morning meal, they have to go to the bathroom, right? It's not a coincidence, right? It has everything to do with this gastrocolic reflex, that it actually is stimulated by food emptying the stomach into the small intestine. It gets sort of reflexed and pushed through the colon. So eating is actually has a really big sort of tie, a really big link, relationship speaking, to motility of the colon. Even though eating happens way up here and the colon is way down there, there actually is that tie between that gastrocolic reflex and the initiation of digestion in the stomach to sort of push the rest of that chyme through the colon. So that's important to understand. Second, absorption. So approximately 500 to 700 mils of chyme flows from the ileus into that first part of the colon per day. Now, most of the water is absorbed in the colon by some of those things we talked about already, diffusion and active transport. But what's really interesting here is that I want to sort of touch on this for a second. as chyme moves through our stomach into our small intestine, and as things get absorbed and taken out of the small intestines, approximately 80% of the fluid has been absorbed while it's in the small intestines. So that's a lot of fluid, right? That's a lot of liquid that has now been absorbed out of the small intestines. No, I mean small intestines. I'm going to hopefully not try to confuse you. I mean small intestines. 80% of the liquid that moves into the small intestines gets absorbed out of it before it gets into the colon. But not only does water get absorbed, but also nutrients, electrolytes, etc. get absorbed in that small intestines. But once it moves into the large intestines, the colon, it is still very, very liquidy. Okay? It's still liquid. So you think about then, for the rest of that 100%, so 20 more percent, right, of the water needs to get absorbed before it can come out as stool. That entire 20% gets absorbed in the large intestine. So basically only water with a little bit of electrolyte gets absorbed in the colon. So, why do I say that? Why do I make that a point? Because clinically, has anyone ever taken care of someone or has any experience with someone with like a ostomy care, like a colostomy? Okay. I can be completely honest with you. Whenever I was in nursing school and I first saw my first ostomy, be it ileostomy or colostomy, I had no idea what I was looking at. I had no idea where it was coming from or what was coming out or what I should be expecting to come. I mean, I had no idea what I was looking at. I don't even think I knew what it was. I just was like picking up the gown we had a clinical at a nursing home, and I was picking up the gown to like do a bath, and I was like, I don't know what that is. And I'm not saying it as a joke to make fun. I had no clinical background of what I was supposed to be seeing, and I remember my clinical instructor saying, "So what kind of stool content is in that bag?" To be able to check, like, is it good, or do they have diarrhea or whatever? And I was like, I don't even know what I'm supposed to be seeing. Like, I don't know what's normal to see clinically. So if you don't have any contact or clinical experience with a colostomy yet, what it basically is that for some reason they would have to have removed part of the colon, maybe because of cancer or some other type of disease process. And instead then, so like let's say they take out this part of the colon because of a cancer or tumor or something, and they would give someone like a colostomy here in the transverse part of the colon. What it basically means is that they take the lumen, they take the mucosal layer of the colon, and instead of, because now you've cut out this entire part of the colon, they take it out through the abdominal wall and sort of make a cuff of the intestines out through the abdominal wall, and then there is a bag to catch the stool that comes out that the person wears. And that's how they eliminate their stool from now on, because the rest of this colon is gone. So you have to take care of the bag and empty the bag and clean the bag because it catches the stool. And so the reason I'm bringing this up in this conversation between absorption and water content and things like that, would you expect a colostomy here in this transverse area of the colon to be pretty formed stool, or would you expect it to be more watery, more liquidy? What do you think you'd expect to see, clinically speaking, given that all of the absorption occurs so much water absorption occurs in the colon? Maybe medium, right? Probably more formed than if it was here on the ascending location of the colon, but certainly more liquidy than if it was way down here, like right in the sigmoid part. A sigmoid colostomy basically looks like formed stool in the bag, right? Because it's so close to the end. So much of the absorption has already occurred. So given this conversation of absorption, who are we most concerned about? If these are three different choices of where a colostomy may be placed, who are we most concerned about in terms of dehydration and electrolyte and water balance issues? Ascending, exactly, right. Because if you have the stool coming out here, you are skipping all of this wonderful absorption process. You're skipping this. And so people who have higher colostomies have to be really, really, really focused on adequate hydration, drinking way more liquid than probably you and I do during a 24-hour period because of this issue of absorption. And that's what I wanted to sort of bring home to you clinically on this slide regarding the absorptive function of the large intestine. Okay. And we're not going to spend a lot of time about sort of defecation and Valsalva mover with the large intestine. But I just really want to make sure you focus and understand this whole issue of motility and absorption and how important that is in the colon. All right. All right, intestinal bacteria. So the environment of the stomach is relatively sterile because of secreted stomach acid, right? But once you get out of that stomach and you don't have that really low pH anymore because of that, the gastric acid, you start to have more risk, so to speak, of infection or bacteria because you don't have that really low pH environment to sort of kill off the bacteria. So we luckily have intestinal flora, right? We have intestinal bacteria to also protect our gut from any, bad guy that may come into our GI system. So bile acid secretion, motility, and antibody production keep bacteria numbers in the duodenum pretty low, but there's also a low concentration of aerobes in the jejunum, but really where you start to see that normal flora, that normal GI flora, are distal to that ileocecal valve. So when we talk about normal flora of the gut, we really are usually talking about just in the colon, in the in the large intestine. So anaerobes are 95% of the fecal flora in the colon. They really don't have any sort of digestive purposes other than to maybe sort of play a role in sort of the metabolism of some of those secretions from those accessory organs. But really they just are there to protect against infection. And that's very important because we don't have that high acidic environment to protect us anymore. So that's good. Interestingly, the intestinal tract is sterile at birth, but colonized with like E. coli and other, bacteria within a few hours after birth. And really interestingly, within like 3 to 4 weeks after birth, our normal GI flora has been established. So really interesting that it's there to sort of protect us from anything that might have slipped past through that hydrochloric, through the acid in the stomach, or through that immune system response we've already talked about in the GI system. All right. We are almost done, you guys. Yeah. Sure. What causes an appendicitis is that if you do have some type of chyme that's moving through the colon, that gets, because the appendix is like a little pouch off of the sort of a sac off the side of it. If you get some of that food chyme through that little pouch, it gets stuck in there. And so then it does become infected because you have that food just sitting in there and not moving through. So honestly, oftentimes an appendicitis happens because the food that's supposed to be moving through the colon gets through that little pouch and just sits in there and becomes infected. And it becomes inflamed. Yeah. Good question. Yeah, one more question, and then we'll move on. Yeah?
Why is it I know sometimes people say family members will get it a lot. Is it because of where it sits, or is there any correlation?
It could be. It could be structurally, just the way maybe there's a little bit of a larger opening into that little pouch that allows it for food and for things to pass in there more easily than other people, just structurally, physiologically. Yeah, that could be. Very true. All right. We are closing in. What I want to talk to you about a little bit more here is moving now into accessory organs, right? So we've talked a lot about everything from mouth to anus, so to speak. And now we're going to talk a little bit about those accessory muscles that I mentioned at the beginning. So liver, gallbladder, pancreas. Pancreas. So before we do that, though, I want to spend a couple of minutes, and we'll probably just spend a couple of minutes here on this, and then we'll probably be finishing up on Monday. But what I want something to be clear to you before we end today is something called splanchnic blood flow. This is the circulatory system. This is the flow of blood from all of those abdominal organs that we've talked, or GI organs that we've talked about already: esophagus, stomach, small intestine, and then also the accessory muscles. That is, when you hear the words or you hear the term splanchnic blood flow, I want you to think it's the circulation of blood to all of those GI organs, and then the blood from those GI organs back up to the heart. Okay? When you hear splanchnic blood flow, I want you to think, oh, that's the blood flow that flows to all of the organs of the GI system, and then takes that blood back from the GI system back up to the heart. Okay? So this blood flow is regulated by, obviously, the cardiac output and the blood volume. It's regulated by the autonomic nervous system. It's also regulated by some other things like hormones and, blood flow mechanisms and things like that. But what I want you to understand, and why I'm taking time to really sit here and talk about the splanchnic blood flow with you for a minute, is that the circulatory system of the GI system is so very unique and so very different than any other of the systems that we've already talked about so far in this course. And let me show you what I mean by that. Here we go. Here's the heart, okay? Pumping out that cardiac output, going down into the abdominal aorta, feeding through the celiac artery and all the other arteries in the lower part of the body, feeding all of those abdominal organs that we talked about, stomach and spleen, pancreas, small intestine and part of the colon, rest of the colon, etc. Now, we know, as we've talked about blood flow and we've talked about, the importance of perfusion of organs throughout this course so far, we know that blood goes to the organs. If we're talking about the lung or we're talking about the heart or whatever we're talking about, we know that blood goes to the organs, gets, the blood drops off the oxygen and any other important nutrients that it needs to that organ through the capillaries. Then the venous side of the capillaries takes that blood and pumps it back up to the heart to get reoxygenated through the lungs, right? We know that. Look at this, though. Look where all of the venous blood that leaves these GI organs, where does it go? Does it go back to the heart? Where does it go? Why? Why? And this is splanchnic blood flow. The fact that the GI system flows all of the blood, leaving all of these organs through the liver before it goes to the heart, is what we're talking about when we're talking about splanchnic blood flow. Why? Say it again. Filter out the toxins. Excellent. Why? Like, what do you mean? What? How does that work?
Like we were talking about earlier, how the GI has its own immunity against
Right.
things. It also is like some of the things we ingest could be toxic, like alcohol.
Right. Drugs. Right. Exactly. Alcohol, drugs, perhaps anything else just dirty, right, that we've eaten, any other type of things that may not be great for our system. So instead of taking that blood and just going right back up to the heart and circulating that blood, it has to get filtered. It has to get detoxified. And that it happens through the liver. The liver is the huge sort of filtration system of our blood and of our system in general. And so all of that blood, so to speak, from the GI system, you can sort of think of it as being dirty, right? And so it has to go somewhere to get filtered, to get detoxified before it goes back up to the heart to be recirculated to the rest of the body. And that is exactly why the splanchnic blood flow, or the blood flow of the GI system, is so specific and so unique, I should say, than any other of the the systems that we've talked about so far, because of that detoxification and that filtration need that has to come from that blood leaving the GI system. It's not clean, right? You can think of it as dirty almost, and that it needs to be detoxified. So very, very good. And we'll talk about why, as we talk more about the liver, we talk more about alterations of the liver, we'll talk more about why all roads need to lead to the liver before it goes back to the heart. Yeah?
So is that why blood flow, because like the gallbladder is connected to the liver, so like if you have fat in your bloodstream, it has to go back through first and like be broken down by the gallbladder?
Yes. Yes, exactly. Very good. Very good. Okay. So, I wanted to make sure that was clear before we get into now this discussion of accessory organs of digestion. So, again, liver, gallbladder, pancreas. So here you see sort of the roles, so to speak, of each one of these organs. And we'll talk more about each one as we specifically go through each one. But all secrete substances, and I've already said this, but all secrete substances necessary for digestion of that kind that we've talked about in the small intestines, right? We know that the liver produces the bile. It contains those salts necessary for fat breakdown, so for fat digestion and absorption. The gallbladder basically is just the storage device. It's just the reservoir that holds that bile until it gets dumped into the duodenum. And then the pancreas produces enzymes needed for digestion of specific things like carbohydrates, proteins, and fats. It also is an alkaline fluid that neutralizes some of that chyme that does come in through the, from the stomach. It's very acidic. So it actually helps neutralize that acidic chyme that just got left, dumped in to the intestines from the stomach and makes it more alkaline, because if it's too acidic, some of these enzymatic actions of these important enzymes can't work in such an acidic environment. So it's really important for it to be acidic in the stomach, and then once it gets into the small intestines, it needs to be alkalinized and not so acidic so that some of the enzymes can work, and the pancreas helps do that as well. Interestingly, too, just kind of a FYI, the gallbladder releases bile approximately 30 minutes or so after a meal into the duodenum. So it kind of gives the food time to get digested in the stomach, and then once the food starts hitting the duodenum, the gallbladder sort of knows, okay, it's time to secrete some of this bile into the duodenum to help with this digestion of fat. Did I say duodenum? Did I say the right thing? Okay. I thought you were saying I said something wrong. Okay. Okay. And so here's sort of the location physically of some of these things. Note here that there is this major sort of duct called the papilla of Vater, or accessory papilla, right here. This is where all of these things from the gallbladder and the pancreas dump into the duodenum right here in this little duct. So they all sort of feed into each other and dump right into the small intestines to do all those actions that we've just talked about. So secretions are delivered right into the duodenum through that sphincter, through that common duct right there. Okay. All right. We're going to, let's see, what time is it? Okay. Does anyone see if there's anyone standing outside, like waiting to get in? Are there people out there? Okay. Is there? Okay. Because sometimes, because we go up right until lunchtime, sometimes I can go for a few more minutes, but I don't want to, if there's supposed to be some meeting in here or something, I don't want to be keeping people. It doesn't look like there's a big long line of people standing out there waiting for a meeting or something. Do you guys care if I go a few more minutes? Three more minutes? Can we do that? Okay. All right. What I want to do is just talk a little bit about the structure and function of the liver, and then we'll end there and we'll finish up on Monday. So the liver, located right under the right diaphragm, divided into the right and left lobes. The liver lobules are the little sort of lobes of the liver. They're formed from the functional cells of the liver, those sort of filtration, detoxifying cells of the liver called hepatocytes. Interestingly, it's these liver lobules, these hepatocytes, that actually can regenerate. If there is some sort of injury or some sort of death of some of the cells to the liver is actually able to regenerate to a certain degree. And it's because of these hepatocytes, these functional cells of the liver, that can do that. It's also covered by something called a glycine, the glycine or the glycine capsule. It's kind of a membrane or a capsule that covers the entire part of the liver. It contains blood vessels, it contains lymphatics, it contains nerves. The reason I mention that is that when the liver is diseased, and we'll talk about sort of hepatitis and cirrhosis next week, but when the liver is diseased or swollen, distension of that capsule causes pain. And that's why you have that sort of stereotypical right upper quadrant pain with any type of liver disease or liver inflammation, because it's actually the distension of that capsule that's surrounding the liver. The lymphatics in that glycine capsule can often become pulled, and they can actually kind of start to ooze. So there's actually some lymphatics that may sort of drain into that peritoneal space around the liver. We'll talk about that next week. There's a very specific name for that type of drainage into the abdominal cavity around the liver because of those lymphatics that are found in the glycine capsule, and we'll talk about that more. But other functions of the liver: secretion of bile, metabolism of bilirubin. There's a lot of blood and hematologic functions that play a very big role because of the liver. And some of the other sort of storage of minerals and vitamins and things like that. But we'll talk a little bit more about that on Monday when we talk about some of the alterations of liver function. Okay, again, I like to have pictures for you. All right. We will do this slide and then stop. So again, hepatic portal circulation receives blood from both arterial and venous sources. Well, obviously it's going to get blood arterially because it has to have oxygen just like any other organ, right? And that comes from the hepatic artery. So that branches right off from the abdominal aorta and provides oxygenated blood to the liver, just like any other organ. But the fact that it's the liver and is part of that splanchnic circulation that we talked about, it also obtains venous blood, which is very different than any other organ in the body. And that comes through a vein called the hepatic portal vein. That vein comes from all of those other organs, right, that dump out into these inferior, superior, mesenteric veins, splenic vein, gastric vein, and esophageal veins, all from those organs that dump into the hepatic portal vein and dump into the liver. So again, this is where the liver gets this large amount of unoxygenated blood because it's receiving all that venous blood that's draining off of all of those abdominal organs that needs to be detoxified and going back up into the liver. And we'll talk more about why that's important when we talk more about the liver on Monday. And then lastly, capillaries, right? The capillaries in the liver are called sinusoids, a specific type of capillary that you find in the liver, located in and sort of around and sort of coating all of those hepatocytes. And they receive a mixture of the venous and the arterial blood from the branches of either the hepatic artery feeding the arterial blood or the portal vein feeding the liver the venous blood. So we'll talk a little bit more about that as we talk more on Monday about alterations. So we'll stop there. Like I said, I just wanted to kind of make sure we at least got into talking a little bit about the splanchnic blood flow and talking a little bit about the liver. And we'll continue to do that more on Monday. And we'll also then start talking about alterations. Thanks, guys. Have a good weekend.